So good evening, everyone. Today I'm going to present a case of proliferative diabetic retinopathy with combined retinal detachment along with macular hole in the left eye actually. So right eye status is also PDR. So the nightmare after double trouble in the sense PDR with CRD with macular hole, and nightmare I'll let you know now. So 325 gauge scleral ports were made, and then vitrectomy was started, and fibrovascular proliferations was seen over the disc extending towards the supratemporal arcade and nasal to the disc also. So the careful segmentation of the membranes was done using ILM peeling forceps and along with the cutter, and then delamination was also done carefully, and diathermy is done for all the bleeders. So diathermy is done for the bleeders. This is the primary break which is seen in the superior nasal arcade. And now BBG staining was done followed by ILM peeling. And fluid air exchange was done from the primary break. We can see the fluid level receding and the air is being filled up. And again FAE was done from the macular hole also. Endolaser was done in all the quadrants, and repeated FAE was done for the confirmation from the primary break, and endolaser was done around the primary break now. And siliconal 1500 centistokes was filled. So now scleral ports were closed with 80 Vicryl and SC-DEXA with amikacin was given. Now POD1 pressures were high, 52 millimeters of mercury. So mannitol was given, but in spite of that, pressures were still high in the POD2. Then we felt suspicious. So I was under the impression that maybe the siliconal was overfilled. So again I reposted the case. I did partial SOR and AC reformation also. But in spite of that, it is not that how I was expecting. And again, out of suspicious, I have done the gonioscopy by the glaucoma department for the other eye. So PSCS was diagnosed in the other eye. So then in the subsequent day, this eye undilatedly, so we have done the gonioscopy. So then we confirmed that PSCS was missed preoperatively in this eye. So again now, because of the anterior chamber inflammation was high, so the patient was posted directly for the cataract surgery with IOL implantation, so along with the surgical PI. So the surgery was done. So this was the picture, so that's why we directly posted the case without any PI. So the temporal, this is done by the cataract surgeon, I mean the corneal surgeon. Visco was injected and then side put was placed. With the microrhexis forceps, CCC was done, then hydro. So with the direct chop technique, emulsification was done. So bimanual cortex was first done. So IOL was implanted and surgery was uneventful actually. There is a bit inflammatory membrane which was removed with the McPherson's, and hydration was done. So thing is that in our institute usually the cases will be sent to the retina department after dilatation, so that the same thing will be happening in each and every visit. So we didn't get the chance of seeing undilated, I mean. So after this thing we started seeing undilated, at least the surgical cases. So undilated anterior segment examination needs to be done by the operating vitreoretinal surgeon preoperatively to prevent such nightmares. So because the cataract surgery was uneventful, even the PDR with CRD case was uneventful, but because of this tenure of almost 9 days, so the optic disc became completely atrophy. So that's it. Thank you.